Meeting is called to order.
I request President Rotarian Lal Goyal to confirm the minutes of the previous meeting.
The previous minutes of the meetings were circulated among the members, and as I have not received any objection or observation, hence I presume that the meeting has been confirmed by all. So I hereby confirm the minutes of the previous meeting.
Good evening, fellow Rotarians. I, Ruby Agarwal, Secretary-elect, would be conducting today's meeting in absence of our present Secretary, Rotarian Mathur Agarwal. Today's topic is changing trends in liver transplantation by our eminent guest speaker of today, Dr. Mayank Mathur. I extend warm welcome and gratitude on behalf of Rotary Club of Organ Donation International and would like to give a brief introduction about him. Dr. Mayank Mathur. He is the consultant in surgical gastroenterology, surgical oncology, and liver transplant surgery at KD Medical College and Research Center, Mathura. His qualifications are MBBS, MS Surgery, MCH Surgical Oncology, UK, colorectal and peritoneal oncology fellow, the Christie NSH Foundation Trust, Manchester, UK, surgical gastroenterology in liver transplantation fellow, Sri Gangaram Hospital, New Delhi. He was awarded fellowships FMAS Fellow of Minimal Access Surgeons, FIAGES Fellow of Indian Association of Gastrointestinal Endosurgeons. Over to you, Dr. Mayank.
Hello. Good evening, everyone. First of all, I would like to thank the Rotary Club team for inviting me for this presentation. And I'm thankful for everyone. Hopefully, I'll be of any knowledge for everyone. I believe not all the people will be doctors, but I'll try to be as simple as possible because usually the presentations are made as per the doctors, but I'll try to be as simple as possible so that we all can understand what it is, what we do in liver transplant. I'll tell you how it all started and how it's going on and what we can do better for the world. Are we okay to start?
Yeah, I think the screen is shared. Make it full if it's possible. Full screen, please. You have to make it full screen. No.
That is because I don't have that particular app. It's a different app.
I think you have to cross the properties one on the right.
On the right, on the properties. Okay.
Close this. And then you have to go in the bottom on the slideshow on the top and then play it. No, on the top. The slideshow.
Slideshow on the top. Yeah. There is a slideshow on the top.
Yeah. Start?
Yeah. So, as discussed, the topic which was given to me to be discussed was changing trends in liver transplant and update. Because I know most of the people might not be doctors, so I thought I will discuss in brief what all I'm going to talk about. First of all, obviously we all know what liver is. It is one of the organ which lies in the right side of our tummy, and which helps in detoxifying the toxin substance which are produced in our body, as well as it is one of the major organ which helps in absorption of the nutrients by secreting the enzymes and hormones in our body. So it is a very important organ. You might have heard people having jaundice, which is again one of the major cause is because of the liver dysfunction. You might have seen people saying that they have water filled inside their tummy, which is again because of liver failure. So the treatment, I will not say for all the patient with jaundice
treatments that she has, that it's
one moment, please. Yeah, please go ahead.
Yeah. So I will not say all the patients who have jaundice or ascites, which in common language is water inside the tummy, needs liver transplant. But if not taken adequate action in time, they'll end up having liver failure and hence leading to transplant. Now, simplifying what transplant is taking an organ from a healthy person and putting it into a patient who requires it. So, like we all say that we've got two kidneys and one liver. So people may say, how can you take liver from a normal person and then put it into a patient? It's not like that we take whole of the liver. So liver is one of the part of our body, one organ which can regenerate itself. Like if we take a certain amount of liver and we put it in a patient, the donor who gave the liver will have regrowth of the liver as per the requirement of the body. So this is what is liver transplant is. So if we say from the history, the first transplant which happened was of kidney, and we all know that you might be seeing people around you in your neighbors having kidney transplant. It's very common. The first kidney transplant happened in 1954, and it took a decade, at least 10 years, for surgeons to start liver transplant. Can we go to next slide, please? So you might be seeing that I've written history of orthotopic liver transplantation. So in general language, orthotopic means that we are putting the organ liver in the same place where it lies. In kidney, what you will see if you will talk to the patients, the kidney is not placed on the same place. It's either placed on the right hand side lower or left hand side lower. As far as but in liver, we place the liver exactly in the same position where it normally lies. So first, which I will say unsuccessful liver transplant happened in 1963, following which long-term survivor, which means a patient survived the surgery in 1967. When it all started, it was a difficult surgery. We don't have much of the backup from the critical care, from the immunocompromise, the medicines which can immunocompromise or which can avoid rejection of the donor. So initially, the survivor of the patient was very less, up to 10%. Then it was 35% in 1970. It was 70% in 1980. Then we started doing different type of transplants. So initially, what happened? We used to take liver from the patients who are diseased. Now, what diseased means is, like suppose an accident happened, or and a patient reached the hospital in a state that we can't take the patient back to the normal, and the patient is so sick that patient may die after an accident. So if the patient have donated their body, their livers and kidneys and different organs are taken, and hence transplant team comes, they all the organs and they are used for the transplant. So there are different procedures how we do. We'll go through gradually how it happens. Can we go to the next slide? So as I said that, no, back please.
Back one.
Infection.
Please, babe.
Back.
ये पढ़े चश्मा लगा के पढ़ो क्या है ये क्या आ रहा है
Please change the slide.
वो आ गया तो कोई हाँ, तो तुम तो वैसे ही रखो चश्मा लगा लो
Back please. Ruby ji,
Please change the slide.
can we move back please?
Rotarian Ruby Agrawal, are you there?
Yes, I am there. I'm just trying to do, I've made a full screen now, so I'm just trying to see where to go for going to back,
You just have to press the back button, the arrow of the back. It will go back automatically.
Just try that arrow. Is it possible?
Yeah. One more. Yeah. Next one. Sorry. Next one. Yeah.
It's fine.
So,
Yes.
yeah. Thank you so much. Thank you so much. So as I said that, people may believe that liver transplant is a very big surgery, which actually it is. But what has happened gradually since we all started, that as I said, the survival of the patients was very less initially. It was up to 10%, reached to 30%. Now we can say that 1 year post-transplant survival is at least 90%. Because I will say it is because of the technique, because of the critical care backup, the anesthetist team, and the immunosuppressants, which are gradually increasing, and we are getting better medicines, antibiotics, and antiviral drugs, which helps in the survival. Can we go to next slide, please? So now, since initially what I said, that not all patients who had liver disease requires a liver transplant. So there are specific indications. I mean, people, those having these diseases may land up having transplant. I will not say all the patients with these diseases may have, but if they're not treated properly, they land up having liver transplant. I will say most common among them are patient with hepatitis, which is very common, which can spread through blood transfusion, uh, by the infected mother giving a birth to a child. Even sometimes the child is born with a disease called as primary biliary cirrhosis, which is one of the most common cause of liver transplant in kids. Then we'll say hepatitis B and C are the next most common. And gradually, which is increasing, is alcohol-related cirrhosis of liver. You will see patients who take large amount of alcohol for years and years. They land up having liver failure, and then they require liver transplant. Rest of the indications are rare. I don't believe there's a need of discussing about it, but these are the most common causes. Can we go to the next slide, please? Now, coming to, like, I will say, I told you what all patients require transplant, but again, it's not a simple thing, and not all patients with these diseases with liver failure can get a liver for a transplant, because there are certain contraindication. Like if you are having an active sepsis, which means you are having an infection in your body, we can't do a liver transplant. If you're having a cancer outside the liver, we can't do liver transplant. If there are any anatomical, which means the built of your body inside, if there's some abnormality, we can't do liver transplant. You are not fit for surgery, you are very old, or you are active alcohol drink. I have seen patients who stop drinking alcohol, get the liver transplant done, and 6 months after the transplant they think they are back normal and they start drinking, and they'll end up having again liver failure. I've seen patients having liver transplant twice, thrice, and patients with active AIDS, which is acquired immunodeficiency syndrome, they are also not a candidate for liver transplant. These are the contraindications. Can we go to the next slide, please? Next again. No, we have to move ahead. No, we are going back now. Once more. Thank you. So now coming to the indications, like if we'll show east and west, which means if we see the eastern part of the world, which means all the Asian countries, and the most common cause is hepatitis B and hepatitis C virus. Then comes alcohol intake. But if we see in the Western countries, it's distributed in every pattern, because here in Eastern countries, we don't take care of blood transfusion and infection control a lot. Hence, hepatitis is the most common cause. But in Eastern world, like United States, in European countries, because there's a very strict control over the blood transfusion and infections, you will see the distribution for liver failure is equivalent with all the things. So I will say this is one of the hepatitis is one of the important thing. If we try to control, the requirement of the liver transplant would be less in future. Can we go to the next slide, please? Next again. Thank you. So then the next common causes, I've told you hepatitis, I've told you alcohol intake. The next common cause is hepatocellular carcinoma, which means liver cancer. So initially what used to happen, obviously in most of the countries, they still don't do liver transplant for hepatocellular carcinoma, but it is an indication, which means we if we are able to get a donor, or if then we can also treat hepatocellular, which is liver cancer with a liver transplant. But there are certain guidelines which we have to follow for every cancer, because it is the third most common cancer worldwide with a very high mortality risk, more common in males, more common in patients with liver disease, and we will say it's around 5,60,000 patients every year. But it's not that common in India, but it's more common in China, South Korea, North Korea, and some parts of the Africa. Can we go to the next slide, please? So, what I will say, at the moment, more than 20,000 liver transplants are performed annually worldwide. And we always say United States of America is the leading. What data I'm showing is from 2009, but at that point when USA was doing 5,000 transplants, India was doing 500. And gradually, what you will see, it's now increasing in India. Last time when we did counting was in 2021. We were doing around 2,300 transplant every year. So gradually it is building up, it's increasing. Because of the awareness, I believe. Can we go ahead, please?
Dr. Mathur, I think you can also control now the slide change.
Can I do that?
Just check.
No, I can't. No.
There is a provision in the Zoom for that. No? Okay.
No.
Okay,
Yeah.
fine. Please.
Yeah. So what used to happen in the past, since I told that we used to have cadaveric donors, and I will still say in the Western world, still cadaveric donor is the most common way of doing liver transplant. Now coming to two types of donor. So one is the cadaveric donor and other is the living donor. So difference is, as I told you before, suppose if a person is in coma and we believe that the person will not be able to recover well, or if there's an accident which happened, and if if a patient who reached the hospital in a state that they will not be able to recover, it's a very good chance that we can get organs from these patients if the family and patients in the past have donated their body. So we say them, can we move to the next slide, which I was talking? Yeah. So they are called as, I will not say cadaveric, they are called as disease donor. It is more common in European countries, in United States of America, but in Eastern world, you will see it is more of living donor as compared to cadaveric, because here what I have seen people saying that in they don't believe in giving the donating the organs, because they think that if a body will in the if the body will be burnt or buried in whole, then there will be no disability in future, but which I don't believe is the right way of thinking. Can we go to the next slide? So what are the problems? The problems are, as I told, what is orthotropic liver transplant means? We transplant the liver in same place where it is lies. The is only Liver transplant is the only treatment which improves survival rate in patients with end stage liver disease, which means with liver failure. It is the only treatment for the patients with liver cancer, with cirrhotic liver. And globally, if we say there are 1.4 million deaths which occur because of chronic liver disease, which can be controlled either with medication if taken on proper time, or with a liver transplant if done on the right time, which is also important. Can we go ahead, please? So we have seen that more than 75% of patients with end stage liver disease, they land up waiting for 6 months or they die before having liver transplant. So what we are seeing gradually, it may be because we are diagnosing more, or it may be because that we are having patients with hepatitis or alcohol related cirrhosis, that the wait list is growing gradually more and more. It may be because that we are aware now that treatment for liver failure is liver transplant, or liver cancer is liver transplant, but gradually the wait list increasing. In 1998 it was 23%. Now it is 54% of waiting. Can we go ahead, please? You can see that there's a huge gap between the demand and supply, number of donors to patient waiting list, and it is gradually increasing and increasing. And I will say, until unless a prompt action is taken, it will be the same way how it is going. We have to look into. We should start thinking that if we can start donating the organs, like I have seen cornea is very common, and because it's not only disease donor, like if we have got two kidneys for kidney transplant, we can give one. It's just the awareness. People think if we donate something we will die, but I will tell you, it's very important message that if something happens to donor in any hospital, I will say that's the end of a transplant program in that hospital. So you can think how important it is for a team to take care of a donor, which is very important. Can we go ahead, please? This is again, the slide is showing how long is the wait list. You can see in the bottom chart that majority of patients they die rather than getting a liver transplant. The blue one are the patients who waited and died, and the red one, sometimes what happens if we wait for long, it starts with liver failure, taking into kidneys. Then you can have liver as well as kidney failure. Sometimes patient have jaundice so much that the bile which is secreted from the liver, they reaches the brain, patient land up into encephalopathy, coma, and sometimes patients keep on waiting and they become unfit for surgery when we find a transplant liver. Go ahead, please. Now, you will say that there are two ways of getting a transplant. Either your relative can give you, or you can register yourself to different registers of organ donation. But there is a way of, suppose I have registered myself at Safdarjung Hospital for a liver transplant. There's a huge wait list. It's not that if I've registered earlier, I will get a liver before as the person who have registered later. There is a certain criteria with which we find out that among 100 patients on the register, which are the patients who require liver earlier as compared to rest of the people. So there are two common scores which we check. One is child pug score, and the next would be the MELD score. Can we go to the next slide? I will not go into details of how these are calculated, but you may say that I have registered myself in 2005, and there's a patient who registered in 2006 or 7, received the liver before as compared to one who registered in 2005. So it's a system or a calculating system through which we say by giving a liver to a patient who will be beneficial more as compared to rest of the people. So this is the MELD score. We say it is it calculates on the basis of your serum kidney function test, liver function test, and the clotting factors. We also now use sodium levels, and this is one of the most important calculating score by which we decide whom to give liver first as compared to rest of the people who are waiting. Can we go to the next slide? So the usually score is from 6 to 40. Higher the score is, I will say it's acute. I mean, the patients who have score of 8, suppose you've got two patients, score of 8 and score of 20. Patient with a score of 20 will be preferred by the team of liver transplant to be given liver as compared to one with score of 8 or 9. So if you have registered yourself in a hospital, it's not just that you have registered first, it's a scoring system which makes you come on the list. Go ahead, please. So, as I said, this is the projected lifetime with or without transplant with MEDAL score. You will see the more the score is, the better. So, because I will say, it's very simple to know the patients who are more sick with the liver disease, obviously, they are having bad quality of life, but they are about to die also. So, if you give them liver, I will not say they will, sometimes they can be back to normal, but they will survive definitely. That we can do with liver transplant, but they have to be in whole of the life, they have to be surveillance, they have to be in continuous surveillance with a surgeon, with a hepatologist, and they have to take very good care of themselves as far as the infection is concerned. Can we go ahead, please? Next. So now coming to who can donate, because obviously I am talking in organ donation Rotary Club today. So the point is who can donate a liver. So the ideal donor, I will say if I'm the surgeon, the best patient with which I will be happy with would be a donor. I will not say patient, a donor with the age of less than 40. Although the most of the hospitals they will say 50 or some may say 60, but the ideal, the best is less than 40. And I will say patient who had a trauma as cause of death, which means they had an accident and they reached the hospital. Because if you will say accident is just a luck, that the person who is driving, moving in a car or in a train was a fit person, less than 40-year-old with no issue, had an accident and then died. Those are the best donors. Or I will say donation after brain death. uh, the donor should be hemodynamically stable, which means their blood pressure, the pulse rate, they should be normal, with no fatty liver. Although it's very difficult to find those kinds of liver in North India, I will say in most of the India, and with no infection or active malignancy. So initially these were the criteria, but we know it's so difficult to get these kinds of donors. Then gradually what we are doing, we are extending the criteria. So we say extended criteria donors are any donors who doesn't match the ideal donor, but still we look into the age, which should be less than 60. uh, Now we can even take donors who are positive with hepatitis B or hepatitis C, uh, with disease donor. But the only problem is if you're not getting an ideal liver, the outcome of the transplant will also be not good. There may be delayed function of the liver, the transplant liver. It will be delayed function, or I will say early rejection. And sometimes the patients who had not very good livers, they struggle whole of their life, and they may sometimes need retransplantation also. Next slide, please. Um, how will we say, like cardiac death? What is cardiac death? So if a patient dies and if we stand off for 5 minutes and it is certified the patient is dead, and if we know that the patient have donated their body, we have to in emergency we have to call the transplant team who have to take the organs out. Because the more time we spend, there's no use of taking out the organs. So the only problem with cardiac death is that we have to be very prompt in taking out the organs. Otherwise the organ will be of no use till the time it will reach the person who need it. uh, Next slide, please. Now, suppose I said that if you're not getting an ideal donor, we have expanded the criteria of donation. But what are the implications? Like, what are the problems which a recipient, the person who is getting a liver, can face? Like, if we are having a advanced age liver or liver with fatty liver, there will be delay in the function of liver. If we are having liver from a hepatitis patient, obviously the recipient will have infection. If there's history of cancer in a donor, there are chances that the cancer may come in the recipient also. So they are different. Obviously we have to be very um, cautious if we are extending the criteria of the donors. Next slide, please. So now, when we start assessing the donor, as I said, we are very strict. We have to be very cautious that who can donate the liver. In ideal scenario, age should be less than 40, but age 18 to 50, with BMI of less than 30, with no other disease. We have three people, and in liver, I specifically say it's important to have the same blood group or O positive blood group, so that we can match. It has to be matched, blood group matched donor. So what, they are different investigation. So when I said it has to be blood group match, then we do some blood investigation. We check hepatitis antibodies, we do CT scan to find out how the liver of donor is. Suppose we match blood group and the donor is 30-year-old with less BMI 30, blood group is also matched. But if you see, if the recipient, mean the patient is around 80 kg or 90 kg and donor is 30 kg, the weight of the donor, I will say, is nearly one fifth of the liver size. So liver is around one fifth the size of weight. That liver will not be sufficient to help a patient who is 90 kg. So that is very important. So you can't just call anyone and ask for the liver. It has to be weight is to liver match. So we do a CT scan, we take the volume of liver, we take the liver biopsy, and once it is all confirmed, then we say, okay, we are ready for the transplant. Can we do next? Next, please. So as I said, we have to see the weight and volume of liver. So in a CT scan, you will see this hole, the yellow and red is a liver. This yellow is the one which will be donated, and red will be the one which will be for the patient. This is what ideal scenario is. Sometimes we take left part of the liver, sometimes we take right part of the liver, but it all depends that the weight is to graft ratio should be more than 0.8. Next, please. Now coming to recipient, suppose I am having some liver disease, there has to be certain investigation through which I meet the criteria of getting a liver. So we first of all we find out what is the cause of liver disease. Did I had any transplant in the past? Did I had any bleeding from my stools or from my mouth? Is there any fluid inside my tummy or any infection in tummy? Do I had any coma because of liver disease? Do I had any surgery in the past? I've got diabetes, hypertension, heart disease, and obviously the score which I have told you in the past, in the previous slide, the child pug and melt score. If I met all these criteria, then they start investigating and preparing me for the transplant. Next, please. So we did cardiac assessment, respiratory, kidney. Basically, the most important, the aim is, if we are doing a transplant, at the end of surgery, we should have a patient who survives. We don't want to give a liver to a patient whom we think will not be surviving for 6 months. So that is of no use. You take a liver from a donor and you give to a person whom we believe is having a cardiac issue through which we can die, a lung issue through which they can die. So it should be, it's not an easy criteria to match as a recipient also. Obviously, donor is difficult, but getting a liver is also a difficult thing. You can't just do liver transplant in a patient who had failed heart or failed lungs or failed kidneys, because it's of no use. If the liver is okay, he will die of cardiac issue, he will die of kidney issue. So we have to rule out everything and then take a patient for the transplant. Next, please. Now it's very surgical thing which I'm talking, but I'll tell in brief. So I said cadaveric, like the one who came with the accident with a coma. You will see on the left picture that you can see the whole liver. So if we get a diseased donor, it's easy. We can get a whole liver transplant into a patient, which is always better for patient. It works very well, and you will see the recovery is so fast, which is unbelievable. You can't, maybe in 15 or 20 days, once they're out of hospital, you can't say the patient had a transplant. They will be like a normal person because they have a whole liver. Now, coming to the right hand side is a split, which means this liver was donated by a living person. Suppose I'm giving liver to my dad. So they have taken half of my liver and half of the liver is transplant to my dad. Obviously, this liver is having a shock. It is cut into half. This liver will be adapted by the patient's body, and it will gradually starts working. So split liver is not as good as a full size liver, which we can obviously understand by in a normal sense. So we get a full liver, obviously good outcome. Split liver, it takes time, but obviously patient will improve gradually. Next, please. So I said the good part with split liver is, suppose in diseased donor, like an accident person came, initially what we used to do, we used to implant the whole liver, the big size. But because of the less number of livers available, we split the liver into two, and now we implant one liver in two people from diseased donor. So which is obviously, rather than helping one person, we can help two person. So this is the benefit of split liver transplant. It was started first in 1969, but you will see it's building up gradually. It happens more common in Eastern countries because there we have got disease donor more as compared uh, to subcontinent or in Asian countries. Next, please. So again, DDLT is disease donor. We get whole liver. In living donor, it's a complex surgery. We have to take half of the liver from the donor. We have to, in the left one is the living donor one. We take half from the donor. We put it into the body in the same place. It's very complex surgery because there are very minute tubes which we have to join to different part of the artery to artery, vein to vein, and duct to duct. But obviously, we always say disease donor have a better outcome, but it's a public property. You can't just say, I want to get a liver. It's up to the scoring system. There's a huge list, a huge waiting list. But if you have a family member, I will always say India is one of the country in which we do living donor transplant, that a family organ comes to the hospital. Family member, we cut the liver into half and we implant it into a patient. It is also very common and very successful. Next, please. Um, it's a big surgery. It takes at least 6 to 8 hours to take out the liver from the donor, 10 to 12 hours to take out infected, or I will say diseased or disease liver from the patient and implant a new. So it's a long surgery. Patient stays in the ICU for 6 to 10 days. Donor for at least 1 to 2 days. Donor is sent home in 3 to 5 days. But I will say, as far as the recipient, the patient is concerned, they are in hospital for 6 to 15 days. Next. Next, please. Go ahead. Uh, Obviously, we can't just say that if you have a transplanted kidney or liver or lung, you are back to your normal life. It's not possible. What we are doing, we are extending your life and we are improving your quality of life. But there is a limit for it to act. I will say if the organ doesn't stop working, there's something else which will stop working and then you will die. So you will say kidney and liver are one of the most common done transplant with a very good success rate. We always say that they have got excellent short-term outcome but poor long-term survival. Next, please. So what we have seen is that if we have done a transplant, there's very less likely that patient die of transplant misfunction or dysfunction because you are given medicines to decrease the body of your immunity of your body. You get infections with which you can die. Patients, because they are given medicines which decreases the immunity, they get malignancies. Because of cancer they die, or they die of some vascular deformities. Next, please. Liver patients had second highest incidence of chronic renal failure. Because what happens once your liver starts decreasing in function, the transplant organ stop, I will not say stop functioning, or it's decrease in function, they start affecting the kidney because of medicines. So your kidney becomes start getting failure as compared to liver. By the end of 5 years, you will say majority of patient had renal failure and they land up having renal transplants also in future. Next, please. I told you in the starting that liver transplant recipients are becoming older with higher MELD scores, which means MELD score, which there is a criteria of giving the liver. So the higher the MELD score is, sometimes we say patient with the age of 30 with a higher MELD, they are more older as compared to a patient of 65 with less MELD. Like obviously, if a liver is very bad, your rest of the organs behave as if they are 70-year-old. But if your liver is not very bad, your actual age represents you. I think I am able to make people understand that. Next, please. Now coming to, as I said, one of the most common factor of indication of transplant is hepatitis. So, if a hepatitis C patient receives the liver, it doesn't mean we have cured hepatitis C. It will gradually come back. The reasons are, obviously, we have removed the liver, hepatitis is gone for a certain duration of time, but because of the medicines which we give to decrease the immunity of the body, the infection comes back again. Next, please. So obviously, patient with hepatitis C recurrence with reduced patient survival. Once they get the infection again, the whole cycle starts again. They'll end up having liver failure. Next. I will not go into that, but it is just to show that it's not that every patient with liver cancer can be treated with liver transplant. There are multiple criteria that that tumor should be less than 2 centimeter. Uh, it should not be more than 3. It should not have involved vessels. There are multiple factors, and it's very difficult to find out a patient with matching all the criteria in whom we can do a liver transplant. Next, please. Next, please. And obviously, so as we know about cancer, they are very notorious. You take out the cancer, it will come from some other place, even if we have not find out that in the past. Suppose we have done a liver transplant for a cancer patient who might have matched all the criteria of getting a liver, but it's always possible that the cancer may come back in any other part of the body. That's what we all know about the cancer. It can come back again from any part of the body. Next. Now, obviously, I said in 1950s, when we all started, it was very that 30% of the patients survived. It was because of the infection or the rejection. But gradually, with the development of medicines, we have got so good immunosuppressions. But that's why nowadays we are able to transplant kidneys of non-blood group match people. Like a blood group A patient donor can give a kidney to blood group B. It's all possible because of immunosuppression, because we can decrease the antibodies in the body. We can make them calm so that kidney can be accepted, but it's not very common in liver, but kidney can be accepted. It's gradually building up. But the point is, it's like a double-edged sword. If you decrease the immunity, the transplant organ is received by the patient, but then you land up having infections, cancers, other thing. So it's a double-edged sword. You have to balance it very well. Next, please. Next. As I said, because of the very good medicines, the incidence of acute transplant rejection is declining, and we rarely see rejection of liver transplant nowadays. Next, please. Next. So it's a balance. The immunotransplant medication, the medicines which we use to decrease the immunity, it's a balance. As I said, double-edged sword. We have to balance it so well that we have to give it in an optimum way that it reduces the body immunity, but it doesn't affect the other organs of the body, or it doesn't affect get any infection or any other cancer. That's why you will see if a patient who has got a transplant, they will go to hospital every second day to get some blood tests done. Those are done to just measure the levels of the medicines which are given to decrease the immunity. Next, please. Next. Next. So, as we say, the first transplant was done by Thomas Tals. Ending to the summary, I will say we have to find an optimal patient and an optimal donor, first of all, to do this. People used to say in the past, if you've got liver failure, there's no option. But I will say, liver transplant, I have seen it changing. Although I'm very, very young in this field, but I've seen in my 10 to 15 years of surgical career, I've seen trends changing. People were so afraid of donating livers, but now you will see in Delhi there are 10 hospitals who are doing liver transplant, and in North India you rarely find any diseased donor, which means patients with accident or dead bodies or cadaveric donors who donated. It's so common that a family member come forward, they give the liver, and the only message which I will try to give is that donor, because the patient is sick, right? If something happens to patient, they were sick. It was just a trial to save a patient and increase the longevity of life. But the most important thing in a transplant surgery is a donor. That's the most important message. So that people can come forward, the family members can come forward and donate the liver or kidney, whatever it is. But again, a message, the most important thing in the whole surgery is the donor. Because if something happens to donor, the transplant program from that hospital will stop forever. Thank you so much. Hopefully, it was of some use.
Thank you. Thank you very much, Dr. Mayank Mathur, for giving so much exhaustive description about the liver donation. Although I know it's a very complex subject and it's to be for the medical professionals, but still you tried your best to explain to laymen like us, although we have few doctors in our club also. But I would like to just give an update that up to 2023, in the year 2023 in India, total liver transplants were 4491. It's a NOTOS figure, updated NOTO figure, and out of which living is 3643, and the deceased or after the brain death is 840.
That's what I was saying. In India, living donor are more common as compared to disease.
Yes. Now, after seeing your presentation, I have questions. Then I will open to the discussion. First thing is you have mentioned about the cardiac death. Now, cardiac death in a hospital, if it happens, then only you can you have.
That's the only way.
But the problem is because in India it is controlled for the wait list. Now, how it is possible that that wait list patient is also available at that certain time, because you are taking out and you have nothing, and you know that for NOTO or SOTO, to get the wait list patient identify and see that he or she is in place, it takes almost 24 hours minimum. And I'm sure that by the time the liver will be of no use. So what is your view about that?
So basically, you know, I was in Gangaram, and there have been instances when a brain dead patient was there, or basically, you know, in hospital, if a patient is in ICU, I will give you an example. And if they are brain dead, and if we think they are going down, then the transplant teams are sort that, you know, there might be a patient who may die and they have donated their body, start contacting the patients. And I have seen
that is called brain death. What about cardiac death?
So in cardiac death, it's the same thing. You know, when we see patients in transplant clinics, we keep on seeing. So it's not only transplant clinic. We have hepatologists who have patients coming to their clinic who are very sick, and they just keep on taking medicines. So it's like a club of team, hepatologists with the surgeons. It's basically all luck, I will say. It's all luck.
But Dr. Mathur, my question is a bit different. My question is, in brain death, the patient's relatives are aware, and the coordinators are working, trying to convince them, if in case it is the same situation, the patient is on ventilator. But on a cardiac death, which can occur any time, you cannot presume that this patient is going to die after 1 hour or 2 hours, and you cannot talk to the family as a coordinator or as a team to say that no, the patient is dying, so we want organs. In India, I don't think, although they have done 1 or 2 kidney transplant surgeries, and the question again comes, it's the illegality, because as you said, the criteria of wait list depends on the, so why you are at Gangaram, why only at Gangaram, why not at Apollo, or why not at like that. But anyway, so it is now. Second is in kidney we have seen the swab donation or the chain donations. Is it not possible in liver also the same?
We do that in liver also, swab donations. So there have been instances then that, but it's a very good, long paperwork, but we have discussed with both the families. You've got A blood group, you've got B blood group. It's possible that we can do it. We have done the swab donations. It's growing up. It's common. It's not.
In India also?
Yeah, in India also.
Okay. So because we have 2 members in our club. One is a living liver donor. She has donated to her husband, and she is our honorary member, because we have made a principle in our club that whosoever donates a living donor, we will make them honorary member. And her husband is a recipient, and both are living happily. And they have participated in the organ transplants games, World Organ Transplants game held in USA 3-4 years back, where they have participated in different athletic meets. So and they have a child after she has donated the liver, so everything is very good for them, because what you have mentioned and what I could understand is that you were mentioning that about the chances of cancer. But in India, fortunately, we have very less chances of cancer in comparison to Western world. Okay, so thank you very much. It's a really very interesting. But now I'm going to open it for all our members. I just request the members pointed only the technicalities or those things which are connected with the liver to ask the question to Dr. Mayank Mathur. Please unmute and ask the question one by one. If you have any question, please.
Dr. Mayank, Raman Goel here.
Hello. Good evening.
Just wanted to check, about the immunosuppression after liver transplant.
Yeah.
How many years does it go on, and how expensive is this?
So I will say it's the kidney which have built this up. They have brought the prices of the medicines have brought down, but in liver it's not as, I will say, as important as compared to kidney. But obviously they will need it till 10 years at least.
Okay.
And the prices are coming down with the competition of the medicine makers, so it's not very expensive. So the initial, like in acute phase, on the day of surgery, a day prior, a day after, those are the expensive injections. But after that, gradually, we'll end up with just one tablet, which you have to take whole of your life.
Okay. And what is the mean survival of your patients? I mean, the liver transplant patients, how many years do you assure them that they are likely to live?
Oh, it's very difficult to say, but obviously we say 10 to 15 years at least, but very difficult to say.
10 to
they
15
may die of something else sometimes.
Yeah, it's very good. 10 to 15 years is very good, actually. Yeah.
I've seen them dying of other things rather than liver failure.
Naturally. Yeah. Thank you.
Thank you, Rotarian Dr. Goel. Now we have a Rotarian Rupa Arora who donated her liver. I just want to know from her that when she donated, how much time passed, how is the health of her husband and herself, because she's the donor, and the surgery was performed at Medanta by Dr. Sones. Yes, Rotarian Rupa Arora, please. Rotarian Rupa Arora, are you there? I think she lost the thing. Okay, Professor, no, I think she's joining. One moment, Professor Saran. I want that because she can. Yes, Doctor. Yes, Rotarian Rupa Arora. Your views.
Actually, sir, नेट कनेक्शन टूट गया था. प्लीज दोबारा पूछिए.
क्वेश्चन ये क्वेश्चन है आपसे कि आपने कब करवाई थी सर्जरी, कब आपने लिवर डोनेट किया था, कितने साल हो गए, और क्या अभी भी दवाइयों पे आप हैं और आपके हस्बैंड हैं, और क्या पोजीशन है, उनकी कैसी कंडीशन और आपकी कैसी कंडीशन?
सर सर्जरी 13 ईयर प्लस हो गए हैं. 2011 में हुई थी हमारी सर्जरी. वी आर गोइंग वेल.
सॉरी, हाँ प्लीज गो अहेड.
वो जो मेरी मेडिसिन है वो तो थोड़े दिनों की ही थी, 10-15 दिन की एंटीबायोटिक्स वगैरह. उसके बाद मेरी कोई मेडिसिन नहीं है. आई एम गोइंग नॉर्मल एंड आई मस्ट से वी आर डूइंग वेरी वेल. और जो मेरे हस्बैंड है उनकी जो मेडिसिन है वो लाइफ लॉन्ग चलेंगी. जो इम्यूनोसप्रेसेंट है वो लाइफ लॉन्ग ही लेने पड़ेंगे. मेडिसिन से ज़्यादा जरूरी जो है हमारा लाइफस्टाइल है, जो हमें मतलब हेल्दी रख रहा है. तो सबके लिए ये जरूरी है कि अपना लाइफस्टाइल और अपनी विल पावर स्ट्रांग हो, तो आप सालों साल आफ्टर ट्रांसप्लांट बहुत अच्छे से जी सकते हैं.
Okay, thank you very much, Rotarian Rupa Arora, and I will tell you that they are doing lots of work for creating organ donation awareness, which is very important, because both husband and wife, although they are government servants, but they are doing lots of work in Chandigarh and other places in North India to tell everybody, to educate that how a person can survive after liver, as you have mentioned, about 10-15 years. But touch wood, they are doing very well, and we pray for them, and we hope that they will be doing very well.
After transplant, we sir participated in Transplant Games of America in 2018 and the World Transplant Games which were held in Newcastle Gateshead in 2019. मतलब हमारी जो फिजिकल एक्टिविटीज हैं, वॉकिंग, साइकिलिंग, वो मतलब हम पूरी नॉर्मली कर सकते हैं. इवन सर्जरी से पहले जो मेरे हस्बैंड थे वो 6 महीने या 2-3 महीने बेड रिडन रहे हैं. हम कभी सोच भी नहीं सकते थे कि वो नॉर्मल लाइफ जी सकते हैं. बट नाउ मतलब मोर देन नॉर्मल हम हर तरह की एक्टिविटीज में, फिजिकल एक्टिविटीज में पार्टिसिपेट करते हैं. We were also blessed with son in 2014 after surgery, after 3 years of our surgery. So that's it.
Okay. Thank you very much, Rotarian Rupa Arora. Professor, Rotarian Professor Dr. Sudhir wants to ask a question. Yes, please.
Yes. Thank you, Dr. Mayank, for a beautiful presentation. And what I am curious to know about is the liver transplant has happened. Suppose liver transplant has happened, then what are lifestyle related issues for males and females separately?
So I will say for a donor, they can go back to normal after 5 to, I will say 3 months, and they are back to normal. No medicines, nothing. But for a recipient, it's same as far as the liver or kidney or any kind of donation is concerned. They have to be very cautious as far as the infection is concerned. Obviously, it's not advisable for them to go to a big public place. They should be very cautious. Hand washing is very important. They can't just have anything outside, because if they get an infection, it will be difficult for them because their body is immunocompromised. They have to be very particular with the clock as far as their immunosuppressant medicine is concerned. They can't miss it. They have to be very important with their watch. If they're eating at 8 o'clock, 8 a.m., 8 p.m., it has to be the same whole of their life. And obviously, if you do well, like the problem with liver transplant is, because if a patient is having liver failure because of alcohol, the patient get back to alcohol. I've seen patients started drinking again, which again is of no use. If you're getting a liver transplant, you start drinking again, they have to stop it. They have to be very cautious in their mind that it will lead to the same situation from which they have come from. They have to be respectful for a person who have donated a liver for them, which they forget as soon as they are back to normal. This is very important for them.
Okay. Thank you.
Thank you.
Thank you very much, Professor Rotarian Dr. Sudhir. We also have one of a member. He is a kidney recipient, Rotarian Sunil Gupta. Are you there? Yes, he's yes, Rotarian Sunil Gupta. Is it possible to switch on your video, or no? It's too early in your San Jose right now.
Little too early. I apologize not switching my video on, but Dr. Mathur, thank you. So very insightful conversation and presentation. I'm a kidney recipient. My wife donated one of her kidneys to me, and it's been 13 years post-surgery. And one of the things you mentioned, of course, a lot of insight into the surgical procedure and selection of candidates and things like that. And one of the things you said, it's an extension of life. You get the surgery through and you provide an extension of life, but the long-term prognosis is and the survival is of concern, right? The quality of life and things like that. So my question is more towards, since I'm 13 plus years living on a transplant with immunosuppression, is related to longevity and how we can elongate the lifespan. As you saw, one of our Rotarian members talked about lifestyle, right? So lifestyle being one, but eventually the body succumbs to the side effects of immunosuppression medications. My question is related to, there's a lot of research going on in the West with anti-aging type of supplements. have you come across any kind of supplementation that prevents, the body to be, stay younger? Whether it's an Ayurveda or whether it's in Western medication, there are supplementations like NAD plus that are getting very popular in the West.
So I will
Your
say,
thoughts?
I always say I'm not against of any kind of alternative medicine. But the point is, if you know what you are eating, like in Ayurveda, I'm not saying anything wrong. I'm not saying anything against it. But if you know what you are eating, or if you know what are the side effects, which is very difficult to know in alternative medicine, I will say you should avoid having it. That's one of the most important thing. You should know what you are having and what it can cause. um, Anti-aging, I will not say. I have been I've known patients having it with a liver transplant or kidney transplant, and there's no study yet at the moment to prove whether it will benefit. I don't believe anti-aging medicines may benefit the transplant organ, but I believe if you live your simple life and avoid any kind of thing which can cause infection. I'm again telling you, in the past, I've told you in the slides that I've seen patients with a normal transplant organs and they are dying of something else. So if you're living a simple, healthy life, there's nothing to worry about.
Got it. Thanks.
Thank you very much, Rotarian Sunil Gupta. Rotarian Girdhari Agrawal, would you like to ask anything or say anything?
Yes. What Dr. Mayank said about the MELD score. The higher the MELD score, the better chances of getting the transplant.
Yeah.
Right?
Yes.
And higher the MELD score, the sicker the person is.
Yeah. That's why there are
The less chances of successful transplant is also there.
Yeah.
Shouldn't be. I mean, the policy, some tweak in the policy is required.
Yeah, I understand what you're saying. So what we believe is transplant should be given to a patient who is fit otherwise but is dying because of liver. Yeah. So the MELD score will calculate the how bad your liver is and how it is affecting your body. So if we change the liver, suppose it's kind of a battery cell. If we swap a cell, will whole of your body work properly? So we always say patient with higher MELD because they will survive. The first aim of transplant is to survive, and the second aim is quality of life.
Yeah, that's right.
First thing is life, and then second is quality of life.
Correct.
That's why it is given as per MELD score for saving life.
Yeah.
Okay.
But I feel that the younger people should get the transplant done earlier so that their life is better.
No, but there are implications. But there are implications of getting a transplant done. You have to take immunosuppressant whole of your life.
Yeah.
It's better to have medicines and get it treated rather than getting a transplant first.
Okay.
So life expectancy, as per you, is less after the transplant.
I will not say less. So the 5-year survival is about 1 year is 90%, 5 years is 70%. It gradually decreases because you are having a organ which is not your body will react to it gradually and slowly. So it's different with different person.
Okay.
Right. This has raised many questions in my mind.
Okay.
Yeah.
I think
Girdhari
Agrawal, if you can send those questions, we'll forward to him because the time is short and we have some more people waiting.
Yeah.
Okay.
Okay.
So thank you very much.
Fine.
Rotarian Deepan Shah is from USA. Rotarian Deepan Shah, are you there? You wanted to say something? Okay, I think he has not. He's there. Rotarian Deepan Shah, he's an expert in the tissue transplant. He himself is a trained skin transplant and tissue transplant person, and he's doing work in New Jersey, and he's promoting organ and tissue transplant there. Yes, Rotarian Deepan Shah, what would you like to say?
Yeah. Hello, Mr. Lal Goyal and wonderful all fellow Rotarians. It was I don't have to say nothing. It was wonderful gain knowledge from me for Dr. Mathur. It was a wonderful elaboration. And what I understand, he is the keen knowledge to the latest technology. Sometimes I read the articles here through the J&J, and what he explained is miraculous. Yeah, wonderful knowledge, wonderful skills he shared with us, and hopefully we can gain something and share with the community also. It was wonderful. Yeah.
Thank you very much, Rotarian Deepansha. Rotarian, not Rotarian, Dr. Mayank Mathur, you have worked in Gangaram, Delhi, and you have also were in Manchester for 3 years or more.
4 years, yeah.
What protocols or what difference you found in India, especially North India, as well as in Manchester, UK?
So as far as the transplant is concerned, what I again say, like Eastern and Western world, in India, North India, it's more of living donor transplant. It's very rare in UK. You get so many disease donor that you don't have to look for living donor.
No, it's not. See, the thing is, in India, the living donor, the brain death donors can be, because in India, at least 3 lakhs people are declared brain death or can be declared brain death. Unfortunately, there are no brain death declaration committee, but hardly, as I gave a figure of only 800 something has donated.
So it's not only the patient, it's the family. You know, in rural cities, in the second part of the country, people thinks if we take the organ of my family member, something may happen in the next life. So that is the mindset. The literacy is very important for them.
No, but for them, the hysterectomy is the example.
Yeah. That's what I'm saying. Awareness need to be brought into.
But the thing is, like you have joined a hospital at Mathura.
Yeah.
Not a single, forget about transplant center, even retrieval center at Mathura, Agra, Aligarh,
No retrieval center.
Eta. So
No.
how you think, what awareness will do? Because if a patient is declared brain death at Mathura, now
no
you cannot ask them to go to Delhi and go give that to donate. So it means that first the requirement is the infrastructure.
Infrastructure, agreed.
So I'm sure now we have joined a hospital at Mathura. Very soon we will have at least a retrieval center or a transplant center, because being a transplant surgeon, we will see, and that will be our aim, that at least in North India we must have only 5 or 6 cities are having transplant center.
Only
80 districts in UP, the revenue district, while in Mangalore, where I am at present, there are 9 transplant centers and 11 retrieval centers, where Mangalore population is less than Mathura. So you can imagine that difference between South and North India.
Yeah,
so
definitely.
That is the thing. Okay, thank you very much. Anyone want any last question, or shall I? Mr. Pradeep, would you like to ask any question or say anything? Please unmute, Mr. Pradeep. No, we can't hear you. I think
it was very nice presentation, very detailed presentation. Now my only one question: when the split is now being accepted, why can't we propagate about the split liver transplant?
So split liver transplant is only possible in deceased donor, the one who is brain dead or cardiac death. But we can't split because it has to be weight is to requirement of liver ratio. So it's not that we can just put 100 grams of liver. So the weight of the patient is to weight of the liver. That's why it's not always possible to split the liver.
But between 2 donors, the family member donor, whether it is possible to do it?
No, so if a living donor is giving, we can't split into 2. It's not possible, because a volume of liver is around 750 grams, and even the donor need a liver to survive. So you can't just take whole liver and split it. So we split and we take out as much as liver is required, and we have, again I said, the donor is very important. Donor should not struggle after the surgery. So it's not possible split in living donors. It's possible in deceased only.
What is the percentage of growth taking place? Growth in the liver after the split?
It increased by 30% in 6 months.
Thank you very much, Rotarian Ramnath Pradeep. Rotarian Dr. Kamal Jain is also with us. He has joined our club recently, and he's also the head of the organ donation awareness program of the Giants group of all over India, having more than 600 clubs. Rotarian Dr. Kamal Jain, would you like to say something or ask him something?
Yes, sir. Good evening. Good evening, Dr. Mathur.
Good evening.
Sir, as you rightly
Can you
mentioned.
switch on your video? Is it possible?
Yeah, of course. I was driving, but
okay.
now at present I can.
Yeah, please, yes.
Hello. Yeah. Hello.
Yes, please.
Sir, as you rightly mentioned that alcoholic problem and hepatitis, these are most of the things, these are the chronic causes of liver failure. But then very common cause, which I think all should know is a acute, which causes acute failure, and that is medicines.
Medicines, yeah,
What
agreed.
we call it as a heterogenic causes.
Yeah.
And the very simple medicine which most of us take daily, paracetamol.
Yeah, very common.
Paracetamol is known to cause a liver failure if it is taken in excess dose.
Yeah.
And especially after COVID, where in India Dolo became famous. Initially, we used to get 500 paracetamol tablet.
1 gram.
Now it is 650.
And
And
1 gram
people
also.
take Dolo like anything, 3, 4, 5 tablets a day. And that is very harmful. And one more thing I would like to ask you about. People in India still, as you had rightly said, that many of us in India, north or wherever you say, have fatty liver.
Yeah.
Now this fatty liver progresses slowly to liver failure.
Liver failure.
Now there is a very good available scan, that is fibroscan.
Fibroscan. Yeah.
Which many of the doctors even don't prescribe, or people are not aware that they should do. Now this fibroscan available is very important. Can you highlight on that fibroscan and how important it is to diagnose and can delay the failure?
So basically, the first way of getting know how liver is performing is a simple liver function test. And then if you say something is going wrong, go for an ultrasound where they can grade your liver to grade 1, grade 2, grade 3, grade 4 liver, fatty liver. But the ultimate test, which unfortunately is not available everywhere, is a fibroscan. There's a scoring system for it. It starts from 4 till 70, and it also tests your stiffness of the liver. So the higher the stiffness is, the bad is your liver, and which means you should start contacting the hepatologist, start taking medicine, change your dietary habits, go more towards the vegetable salads, and it can gradually, your liver can recover very well if you pick it up in the early phase of your life.
Yeah, thank you.
Thank you very much, Rotarian Dr. Kamal Jain. Now, I think before I will hand over to Rotarian Ruby Agrawal, I would like to inform all our members that Dr. Mayank Mathur is the son of our honorable Rotarian member, Rotarian Pradeep Mathur, who is also here today. Rotarian Pradeep Mathur, can you just say a few words about your own son? Just unmute yourself, Rotarian Pradeep Mathur. You are on mute.
He's on mute.
It's a proud moment for a father to hear from his son, such a successful doctor, and to hear what he has mentioned now. Okay, I think some problem is there.
Yes, Mr. Lal, we are talking daily about various issues, but today my son himself has explained the things. So I was measuring his depth, that how much he has studied well or not. He was outside the India for the higher studies, but I'm confident that all are admiring his explanation about the liver function and various other things. I am also happy, and I congratulate him for it.
Okay, thank you very much.
Thank you for
giving me the
organ donation Rotary Club of International that you have invited him for such a precious talk. Thank you for it also.
Thank you very much. And Rotarian Pradeep Mathur, we just hope that with your efforts, being a ex-MLA 4 times of Mathura, at least we will see a organ transplant center at Mathura.
That we will manage, no issue.
Yeah. So that is the main thing which our club is doing. Thank you very much. And now over to you, Rotarian Ruby Agrawal.
Thank you, Dr. Mayank, for such a beautiful, detailed presentation. I would now request Rotarian Dr. Ramin Goyal to please give the vote of thanks.
Okay, thank you, Ruby. It's absolute pleasure to propose a vote of thanks to Dr. Mayank Mathur, whom I know from his childhood days. And I also know how well trained he is. He has been to one of the best centers in UK. I know his boss, who was with Mayank, was with him personally, and I know how good that center is. So, Mayank, absolutely wonderful your presentation today, because you simplified a talk for common people, non-medicos, in a way that it was understandable. And another reason to congratulate is that even after so much education, you came back to Mathura to start a difficult specialty. There is no liver transplant center in Mathura. So I think for that also you and your family deserves to be wished, because it's an important thing. I also, this is an important topic because I lost my best friend yesterday from a hepatocellular carcinoma. He went into hepatic encephalopathy. He's a surgeon in Kolkata. He was president of IAGS before I became the president. I succeeded him, and we lost him yesterday morning. Just 69-year-old, diagnosed very late with portal vein involvement, and transplant couldn't be done. So relevant to hear your talk and mention all the points that took all the scores, all the boxes today. And the last thing is about the lifestyle changes, that discussion that was happening. Fatty liver, cirrhosis, and because of obesity, liver failure is becoming even more common. We published a journal on bariatric surgery. I edited. So we got recently an article from a transplant center in Mumbai, where the wife was having a fatty liver, high fibroscan score, and she got a bariatric surgery done. And 6 months later, once the liver functions improved, she became fit enough to donate the liver.
Yeah.
So I think lifestyle changes before surgery for donor and lifestyle changes for both after surgery are important. And that's important for all of us, irrespective of liver transplant. We should all lead a healthy life so that we don't need help of doctors like us. So thank you so much. Absolutely wonderful presentation.